Very good morning. Today we are discussing another important case, and I think the most important thing as a practitioner is also to know when not to treat uh, a specific case. And this is a case which reported to my clinic, and based on the history, the patient already got re-RCT done 2 times. I am being an endodontist. I always plan to save the tooth, but here I decided that I will not retreat this, and I will tell you why I decided to not to retreat this, and the discussion would help you to understand why the prognosis of this tooth may be very poor. If you look at the case, obviously the reason for failure can be the under obturation of the distal canal. If you have done a retreatment, obviously you will also try to reach the distal apex, and I can see that there is some amount of canal visibility which is present on the distal canal. But maybe it is calcified in a clinical level, but whenever you see a line, it means that there is a canal, which you can always try to open it up and you may succeed. But is that the only reason for the failure of this tooth? Not necessary. The other reason is maybe this case would have succeeded, but the patient has left the tooth without a crown, and maybe there is a vertical root fracture which tend to give you this kind of J-shaped lesion, which will indicate that it may not have a very good prognosis. So you can always advise at CVCT and reconfirm whether it is possible that this lesion is related to the vertical root fracture case. I think another very important reason for the failure may be a strip perforation, which generally happens on the distal side of the mesial root, where we tend to have danger zone. So here the enlargement may be slightly more at the coronal area, and maybe that has led to the failure, and eventually because of the communication it has led to a huge bone loss, and the case has failed. So I think there are multiple reasons, and maybe with CVCT I can actually decide why the failure has occurred, but looking at the amount of bone loss in the interdental area, looks like the tooth is resorbed, there is slight mobility. I don't think we should take a chance of saving this tooth, no matter how good as a clinician, because the patient has already got the re-RCT done 2 times. So those are the few reasons for the failure of this case. If you have anything to add, please mention in the comment section, and I will be happy to answer.